The next awardee is Eli Papaemmanuil from Memorial Sloan Kettering Cancer Center. Please. The title of Eli's talk is Bridging the Gap, Knowledge-Based Approaches to Support Characterization and Translation of Molecular Biomarkers in MDS and Related Myeloid Neoplasms.
I'll try for a shorter title next time, I'm sorry. So thank you so much for this award and the opportunity to present some work in progress in the lab about something that I feel it's not being discussed frequently enough, but something that maybe we should bring to the attention. So of course, we know very much that MDS fits right within a spectrum of overlapping clinical neoplasms, the myeloid neoplasms that share a lot of morphological and cytogenetic presentation, and the recent characterization of molecular biomarkers across myeloid neoplasms has very much rendered their hope, as we've discussed during a number of times in this meeting, to bring these molecular biomarkers at the forefront of patient care to support clinical decision support. And we often think about this in the context where a patient comes in and we identify, or we take their samples and we sequence them in order to identify the repertoire of gene mutations that characterizes that patient. And one thing that I should highlight is that whilst these molecular discoveries have been very recent, the implementation of these sequencing technologies in clinical diagnostic laboratories has happened exceedingly fast. And in many ways, the knowledge that is required to link those findings to some clinical actions is lagging behind, and this is the focus of my talk today. And this is particularly important because what we aim or hope to do for those who believe that there may be room for precision medicine approaches is to link a patient into a molecular subgroup and not only understand the biology, but also decide optimal treatment strategies. So often the conversation focuses on how we can use, and particularly our conversations on how we can use these mutations to inform disease classification, as well as integrate these into formal risk stratification schemas, and how we can predict best treatment options. However, and whilst we focus on these questions, the one question that I haven't at least been much in part of, and that's something that Catherine Cargo in one of our meetings this week said, before we talk about prognostic models, before we talk about molecular classification models, can we talk about which mutations we actually consider? So in a typical clinical diagnostic lab, you will take a patient sample, you will sequence it, you will identify high confidence mutations, and then you will use a number of databases to annotate which ones are putative oncogenic or linked to disease pathogenesis. However, in the context of MDS and myeloid neoplasms, there is a real challenge in that we very often have unmatched assays, so even distinguishing germline variants from real mutations can be incredibly challenging in order to be able to annotate them and put them into a clinical report. And this is a two-stage process that we first need to identify which mutations we believe, and we usually use a range of sequencing metrics and manual curation, but then also which ones, then the next step is to evaluate which ones are relevant. And most clinical centers around the world use pragmatic approaches, which when are being discussed around tumor boards, sound sane in that you say we will take mutations that are recurrent in COSMIC or in one of those databases or that have a known functional role. And in discussions, this looks like a reasonable approach to do. However, when we look at the spectrum of recurrent mutations, over 25,000 patients that have been molecularly profiled in Memorial, what you see is that almost 80% of the mutations that prospective clinical sequencing identifies has been seen only once, even when more than 20,000 patients have been profiled. So this poses a problem when we want to incorporate recurrence as a metric of annotating the relevance of a mutation into a patient's clinical report and form a decision. And whilst for mutations like IDH2, this is relatively straightforward, we know that there are specific hotspots that we understand, both from a functional perspective as well as a clinical perspective. We're starting to learn also that the associations amongst them can be profoundly different. And many people are contemplating the sequencing of mutation hotspots, but we're also learning that resistance mechanism may come with a profile that we don't understand as much, as in the case here of resistance mutations of IDH inhibition. Additionally, even when we're thinking about therapeutic or predictive mutations, they can have very different interactions when it comes to specific targeted treatments. And this is okay when we're looking at mutations like IDH or BRAF, where we have hotspot mutations. But what happens in the case of unmatched sequencing, where we're profiling genes that present with a repertoire of mutations, both nonsense or loss of function mutations as well as missense mutations that do not concentrate within a specific domain across the gene body, then being able to distinguish what is germline and what is not germline and what is functional or not can become pretty challenging, and that's where those pragmatic heuristic rules come into play in order to support that process from identification to translation within the clinic. So we wanted to assess a little bit further this question. So we've put together a phase 1 compendium of myeloid neoplasm data from prior work that has been published predominantly through my previous lab or work that I've been, or collaborators have worked. We've established uniform criteria. We took raw data with regards to whether a variant was highly confident or less confident, and then whether that mutation was deemed to be oncogenic or not. And this included studies in MDS from both Dr. Ogawa and Haferlach's laboratories, including the ICGC study, AML and MPN, in order to try and render power across the myeloid neoplasms. So the one thing that we do know is that the molecular presentation is highly overlapping across these disease states, and that gives us power to investigate some of those associations. And we identified these as opportunities to both develop knowledge bank approaches for variant annotation, but also most of us within our communities, such as this one, we tend to look at correlations between these mutations within the context of MDS, within the context of AML, and within the context of MPN. But we know that these represent spectrums of neoplasms that are largely overlapping. There are patients that fit right there at the diagnostic boundaries. So taking a pan-myeloid approach will provide opportunities both for diagnosis, classification, and better molecular stratification of those patients. However, unfortunately, I'm not going to have time to talk about this today. So in total, in our phase 1 kind of pilot study, we took 8,966 patient samples for a total of 25,000 mutations across AML, MDS, and MPN. And you see the representation of the mutation counts across each one of the cohorts and how these are represented within the data set. And similar to what I presented earlier from the impact data, we see that if we were to annotate this on the basis of recurrence, the very small proportion of those mutations are recurrent. Then we can look against COSMIC or OncoKB, though COSMIC in this particular case is enriched for these particular studies because these studies have been deposited in COSMIC. And then in green, you see the proportion of cases where expert manual curation went and annotated those mutations as being likely oncogenic. We then kind of performed an inquiry of what are the most frequent clinical reporting criteria, and these usually contain hotspot mutations or hotspot exons or domains, also, and then require a level of recurrence within OncoKB or COSMIC. And I'm sure these are familiar to many of you that are working within molecular diagnostic laboratories. So we used that criteria within our data set and say, using established clinical criteria, what would we report and what would we miss? So we found that approximately 30 to 37% of the total variants that have been annotated as putative oncogenic using the pragmatic and stringent and also conservative criteria that we ought to be using in the clinic would not be reported. And the impact would be that approximately 30% of mutations per patient would be missed. So we've shown the impact of additional mutations, but as well as of specific mutations in outcome. And most importantly, while some early low-risk myeloid neoplasms have just one mutation, in 8% of those patients, we would miss that one mutation. So if you look at the genes, and here in green, we have the frequent genes across this neoplasm. In green, we show the mutations that would be reported. And in orange and purple, the proportion of the mutations within every gene that wouldn't be reported. We see that in the frequent genes, the mutations that we would miss are between 5 and 10%. But in the less frequent genes, they tend to be exceedingly high, with up to 80 or 90% of the mutations in those genes not being reported. So if we look at ranks 1, most laboratories will take loss of function mutations, and of course they will report them within the clinic. And here, so there are no indels that would be unreported, but if we look at mutations and we apply those recurrence rules, only the highly frequent or highly recurrent mutations, and this is the spectrum of mutations that would be missed within our pan-myeloid data set. And this is of profound importance because if we look at the outcomes of the mutations that would be reported and wouldn't be reported, we see that they're overlapping. And that means that we are missing the opportunity to identify an adverse prognostic biomarker in those patient subsets. So likewise, this is the same exercise on ASXL1 for both indels and substitutions, reported and unreported mutations, and we see exactly the same thing. So how can we work on trying to build prognostic models that are informed on molecular biomarkers when we haven't really dealt with the issue of ironing out the rules and the information that needs to be put in on the molecular biomarkers that we identify before we even start to have another conversation, such as the one that I presented on Thursday. So, as I highlighted, when we start going on the less frequent or most recently discovered genes, our ability to identify recurrence is proportionally decreasing. And this is an example for PHF6 as well as ETV6 across this data set. So we wanted to evaluate whether we can improve variant annotation to support patient diagnosis, and we've used both the myeloid and the impact data set. And we tried to use kind of modeling approaches that consider a number of features and expertly reviewed labels with regards to whether a mutation is real or not, or oncogenic or not, and try and see whether we can have a supervised approach in terms of how we could prospectively classify variants in the clinic. We tested a number of statistical models, and we see that recurrence has a very low predictive power. But once we put the features together, both from available databases and sequencing metrics, then we get a pretty high predictive power in terms of, and this is the AUC across the models in which we can annotate those variants. So this means that rather than use manual or conservative approaches, we can now have empirical estimates with the likelihood of a mutation being real or not, or being oncogenic or not. And this is an evaluation across a myeloid data set showing that we could classify variants across being truly real, likely true positives or true negatives, and then have a spectrum of mutations requiring to manually curate and evaluate only a subset of mutations, thus minimizing the burden within the clinic. And this shows that these approaches are actually delivering sound information in that here we evaluate the likelihood of a mutation being real and whether that variant is recurrent, whereas this information did not go into the model. We see that our probability for a variant being real and pathogenic is actually increased for those recurrent variants as a positive control. So to summarize, the majority of pathogenic variants in cancer genes are individually rare, and annotation on basis of recurrence is not sufficient for clinical support. Then, in the context of myeloid disease, we are severely underrepresented within the public cancer database, and there's an opportunity and a need to develop variant classifiers that are informed from large and expertly annotated cohorts. So with this in mind, we propose and we hope, with the extended data sets coming from the IWG, to build a pan-myeloid database of over 20,000 patients and try and optimize and further develop this pilot study into formal classification tools where each and one of you could be uploading VCF files and get an informed annotation of the likelihood probability of a variant being real and being pathogenic for disease biology. And with that, I would like to thank Elsa and Pierre Gilman from my lab, who very much worked on this together with the clinical bioinformatics in MSKCC and all the collaborators who contributed samples and data to the study. Thank you very much.